Dr. Ye Hong from China. She's an interventional nephrologist from Nanjing. I think today she's unable to be online, but she has a piece of talk for us. It's for rare hemodialysis catheter-related complication. Let's welcome Dr. Ye.
Distinguished audience, ladies and gentlemen, good afternoon, Mr. Chairman. Thanks for having me here today. I'm Dr. Ye Hong from the Center for Kidney Disease Second Affiliated Hospital of Nanjing Medical University. The circumstances have been tense lately in mainland China, so it's a real privilege to address this distinguished audience through video. Please allow me to devote myself to the topic of rare hemodialysis catheter-related complications. Thanks to the rapid growth of hemodialysis technology with the help of which patients' lives have been tremendously extended. As a result, vascular access plays an increasingly important role. The main types of hemodialysis accesses include AVF, AVG, and the CVC, of which our conceptions have been evolving in recent years. From the principles of AVF first and catheter last to the full right, namely right access for right patient at right time for the right reason. The management of vascular accesses should be integrated with the overall life expectancy planning of ESRD patients. Dobbs research shows that there are still over 20% of MHD patients receiving hemodialysis using central venous catheters as managed accesses. Catheter-related complications severely affect the usage of TCC, thus increasing the rates of hospitalization and fatality. Catheter-related complications include catheter dysfunction, infections, and central venous stenosis. Rare cases of complications include catheter misplacement, vein wall adhesion, vascular perforation caused hemothorax, pneumothorax, air embolism, arrhythmia, etc. These complications sometimes even endanger patients' lives. Here, I would like to share two rare cases of complication during catheter insertion in our center. The first case is catheter distal end misplacement. This was a 32-year-old female with the catheter dysfunction of right internal injugular vein, long-term for 8 months. A catheter was temporarily used for hemodialysis. Then ECAVF was created at upper right arm, but replaced 2 months later by a right IGV-TCC because of AVF maturity. Here, right upper extremity and the central veins was examined by contrast. The results are as follows: a severe stenosis in cephalic vein of the AVF at her right elbow, as well as stenosis in proximal of right brachiocephalic vein. During examination, we found a thick vein connecting the right atrium, which is actually the persistent left superior vena cava. Because of its thickness, we decided to insert a catheter through puncture from the external jugular vein. Guided by X-ray, the catheter was successfully inserted. However, after half an hour of hemodialysis, the patient began to complain of chest distress and palpitation with an ECG showing SVT. Her heart rate ascended to 150 to 180 beats per minute, and blood pressure drops. Suspension of ultrafiltration and blood infusion did not improve any symptoms. After termination of the hemodialysis, her heart rate lowered to 100 beats per minute. Considering arrhythmia may be induced by the PRSVC catheter, we decided to remove it and created another access. Now, let's take a closer look at PRSVC. PRSVC is a common malformation in thorax. The reason for the formation of PSVC concerns the failure of left superior vena cava degradation in the stage of embryogenesis. PSVC is quite often related to arrhythmia. There remains controversy whether PSVC is suitable for catheter insertion. These literatures are recommended. In our opinion, PSVC catheter should be avoided unless no other vascular is accessible. Notably, before catheter insertion, anatomy of intrathoracic vessels should be carefully evaluated by imaging. The insertion should be guided by X-ray. In the process of catheter insertion and hemodialysis, ECG should be continuously monitored for early detection of arrhythmia. Once the arrhythmia induces disruption of hemodynamics, catheter insertion or hemodialysis should be halted and the catheter be removed immediately. Well, let's move on to the next case. Case 2 is about stub catheter occurred during catheter replacement. A 48-year-old female with hemodialysis history of 6 years had a TCC at her right IJV because of her poor peripheral vascular status. Before transfer to our center, insufficiency of catheter blood flow appeared recurrently during hemodialysis. Moreover, urokinase thrombolysis did not work. We decided to replace the TCC with a temporary catheter. Meanwhile, create a vascular access in her upper left arm. Considering the 6-year usage history and the patient's history of secondary hyperthyroidism, the catheter might have been tethered by fibrillation or thrombosed or adhered to the vessel wall. We chose to replace the catheter under the guidance of X-ray. After dividing the cuff, clipping up, detaching and removing the proximal segment of the catheter, we inserted a guide wire through its stem end to the right atrium to pull the stem out. However failed, we conducted percutaneous venography and found EGV were bound by long fillings defects and the initial segment of SVC by annular calcification as shown in figure. After communication with the patient and her family, we chose to conduct endoluminal balloon dilatation to remove the catheter. A guide wire was inserted through the catheter to inferior vena cava. A high-pressure balloon from Boston or Boston Scientific with 5 mm in diameter and 40 mm in balloon length was guided by the wire to the interior of the catheter. The balloon dilated from the catheter interior and the distal tip respectively with the same pressure of 20 atm. After 3 times of inflation, the catheter became loose enough to be removed. Risk factors for stuck catheter include cumulative injury time, insertion site, recurrent catheter infections, venous internal injury, material or catheter damage, implantation, history of standing or placement, as well as vascular calcification, etc. Affiliated hospitals of the University of Toronto removed 2,048 permanent catheters in 10 years with only 19 cases of stuck catheter, suggesting that the incidence rate is comparatively low. Fibrin sheath in the earliest stage forms and appears after 24 hours after catheter placement. There are also few cases reporting calcification associated with the formation of fibrin sheath. There also have been few literature shows how to remove tethered catheter. Most conducted thoracotomy or bari-restore catheter subcutaneously. Hong et al. Reported for the first time in 2011 on method of removing tethered catheter by endoluminal balloon dilatation, with which catheter dilates along with balloon, causing the fibrin sheath that tether the catheter to relieve. Thus, catheter can be removed successfully. Such method is simple but safe and effective. Another method is utilizing laser sheath to relieve fibrin sheath. In summary, these rare catheter-related complications not only cause access dysfunctions, but also induce more fatal complications. Therefore, precautionary measures should be taken proactively. Before the operation, medical history and physical examination should be carefully completed. Angiography is helpful in understanding the vascular situation. Puncture under the guide of the ultrasound is a wise choice. Remember, keep the puncture needle visible. Hidoki recommends the use of imaging-guided catheter insertion to achieve a higher successful rate. That's all for my speech. Thanks very much for your time.